Hello, everybody. My name is Tino Bindo. I'm a fourth year medical student and a member of the Gold Humanism Honor Society, and we're so excited to welcome you all to our panel discussion. This week is Solidarity Week, and the purpose of this week is really to highlight the importance of providing culturally competent care. As physicians and people in the medical field, we really want to emphasize understanding and knowing your patients. It just leads to more personalized medicine and just a better patient relationship. And so we figured the best way to do this was for you all to hear perspectives of people who are in marginalized groups of medicine who can speak to their own personal experiences. And so today we have LQ Goldring, we have Reverend Linda Jackson, and then we have Leslie Small Stokes, or Reverend Leslie Small Stokes, and they're going to speak about their experiences. And it makes it really unique because LQ has seen the patient experience. And also, we're going to have these two, they're also chaplains with U of L Health. And so they've also been on the other side where they've been patients and taken care of patients who are from these groups we'll be representing today. And without further ado, we're going to have our panelists introduce themselves.
Thank you for this invitation today. Hey everybody, my name is LaQuaya Goldring. You're welcome to call me LQ. I'm from Bardstown, Kentucky. I'm currently a graduate of the University of Louisville. I have a bachelor's in psychology, and I'm currently a pre-medical student returning in the fall to U of L to pursue a degree in medicine. A little bit about myself is I am married now 6 years to my best friend, who is also my daily caregiver. Her name is Danielle. Aside from just dealing with the day-to-day with health, I'm a cancer survivor of almost 30 years this May, as well as a dialysis patient for 7 years. I'm still awaiting a second kidney transplant. When I'm not in school or if I'm not dealing with my health, which is a daily battle, I'm helping some way in the community give back in medicine. So I'm looking forward to this discussion today.
My name is Linda Jackson, and you can call me LJ. I am from Louisville, Kentucky. I am a palliative care chaplain here at the University of Louisville. My day of focus is for minority for this time of Solidarity Week. And then also just a little bit about myself. I am a pastor as well. I'm married with children. I am a daughter, and not all in that order, but ministry is my life. And so I enjoy meeting people where they are. And supporting them during the most tragic times of their life. And I'm just glad to be here. Thank you.
Hi, my name is Les Small Stokes. You can call me Les. And I am here I'm a chaplain and a certified educator with ACPE, which means that I teach spiritual care in a clinical setting. And I'm here for LGBTQIA, and I'm married to, my wife is a pastor of a local congregation. She's a lead pastor. We have 2 boys, 5 and almost 4, very close in age, lots of energy and a lot of fun. And personally, we really like cooking and going outside to play, trying to teach the boys some new sports and arts and crafts, fun things like that.
Now, when it comes to culturally competent care, people wonder, why is this topic important? Why should we care? And there's a lot of research studies that exist that just show that patients from marginalized communities actually suffer from certain healthcare disparities, more negative health outcomes, and so many other effects just because of what they're dealing with. For me personally, I actually saw a research study that came out that said Black patients die at a 55% higher rate from spine surgery. And to me, that was a very jarring perspective just to hear. And so I wanted to hear from you all why it should be care. Why does this even matter from your perspectives?
I think it matters because first and foremost, we need to have autonomy in healthcare, and we need to have solidarity. There needs to be a unified front. What I mean by that is collaborative care is important, especially when it comes to a patient like me who is representing the focus of both diversity, intersectionality, and just dealing with multiple health battles. You want a physician, and actually all your physicians, to show up for you, to open up the floor for conversation and allowing you to be comfortable in your environment so that you can have those discussions so that we don't have these high disparities. When a patient is fearful of going to the hospital or going to the doctor, or if a physician has made them feel like they are less than, you can't expect the patient to show up and want to be seen. So it comes back to building relationships and making sure that you can tell a patient if you don't know something, letting them know up front you don't know, but also letting them know you're willing to learn with them and provide them the care they so deserve.
I like how she said building relationships, because it is important. Working as a palliative care chaplain, too often I encounter patients fearful because they're not trusting of their physician or the healthcare system overall. And it's based on their experiences. And so what I like to tell my patients is that I'm on your team. I'm here to support you. I'm following your lead, and all of these providers as well, whether it's an oncology provider or whether it's the social worker, whether it's the chaplain, we are here to provide that holistic support. And so when I encounter patients who are afraid, it's about listening to their stories, right? Because their stories are important. We need to affirm how they feel. Not just overlook it. And so when you see the whole person, understanding why they are afraid, understanding how they got to where they are now, and making sure they understand what is offered to them, right? Knowing all of the options. Even when my patients are at end of life, a lot of my patients who are Black and brown, we know that most pursue aggressive treatment versus passing peacefully, right? Quality of life versus quantity of life. And so it's about building relationships, and it's about the person who has come and is seeking for guidance and for help.
Yeah, I agree. LJ, I like what you said about paying attention to their feelings and letting them know that it's okay to be honest about how they're feeling about this environment. And Tino, I like how you brought in one of the stats about how this really impacts the outcomes of patient care. We know that Black mothers are much more likely to die in labor or just after labor, days and weeks after, partly because historically we don't pay attention to Black pain the same way or respect it. And lesbians are more likely to be obese and have cancer diagnoses. And all of that is related to our the access we feel we have to healthcare. When I say access, I don't just mean like getting to the doctor's office. I mean feeling like I am respected, and that that what I'm reporting as something that I'm concerned about is respected, or that when the physician is asking questions about my life, that part of what I'm going to share is not going to be otherized. A personal story, my wife went to a neurologist recently. I think it was a neurologist, a physician. This was probably 2 years ago, and the physician was getting some background history on her and asked, are you, what's your family makeup? And my wife started with, well, we have a kind of weird family makeup. My wife gave birth to one of our sons, and I gave birth to other of our sons, and the physician's response was, why are you calling that weird? That's not weird. That's normal. And it completely changed her openness to share her experiences with the physician and name other symptoms that she was, in a way that she wasn't conscious before she was hiding. She became much more open to being honest about her full physical experiences.
Thank you for sharing that. And so just while we're on the topic, I actually have a question for you, Les, specifically. We talked a little bit about informed consent when we were putting your video together. Can you talk to us about a little bit about why that's important and what that is first and foremost?
Yeah, I'd love to. I think we talk a lot in medicine about informed consent. And so many times it's easy to pass informed consent off as, I need this paperwork signed in order for me to proceed with this course of treatment. And patients, family members, etc., we don't always know what it is we're agreeing to. It's not just this procedure we're consenting to. It's the long-term impact of those procedures. And as a chaplain for several years, I was with the Brown Cancer Center before we had a fully designated chaplain for the Brown Cancer Center. I worked in palliative at the Brown Cancer Center. We had several patients who, and some of them, it was related to their LGBTQIA status. Their cancer and their life were directly intertwined. Not enough questions were asked before they sought treatment, and the long-term impact of how they were in relationship with their loved ones afterward, specifically related to sex, or related to their ability to procreate. Some of that was related to sexuality, some of it was not. They didn't understand all of the long-term impacts. I saw this at Memorial Sloan Kettering Cancer Center in New York also. The women with ovarian cancer and the treatments they received, and over and over again, patients would say to me as a chaplain, if I had known that this is what it would be like, I don't know that I would have consented. So informed consent is not just about, can we do this treatment? It's, do you understand the financial impact of choosing this treatment or not choosing it? Do you understand the physical and relational impact of choosing this treatment or not choosing this treatment? It's not a quick thing. It's a long conversation and requires more information about how people live their daily lives.
Add anything to that?
Yes, I'd like to add something to that. So as a dialysis patient, I've had to undergo hundreds of surgeries on both of my arms. And I remember when I first went to see my vascular surgeon the very first time, he walks in the room and he stands about 6 or more feet from me without even looking at my history or touching me and says, I already know where I'm placing your access. Sign the paperwork, surgery set up, see you in a couple weeks. Now for me, I kept questioning, as well as my family, like, are you going to do vein mapping, which is what they're supposed to do, before placing a permanent access in your arm for dialysis? He kept saying, you're small, that's all I need to know. He didn't look at my actual weight. He just assumed because I'm small-bodied that he automatically knew what was best for me. And in return, after getting the surgery and feeling like, okay, well, he's the surgeon, he has the education, me and my family shouldn't question that, go with that. I learned from a hard experience when it came to those long-term outcomes that my arm was completely destroyed and the surgery couldn't be reversed once it was done. And then in addition to waking up on the table, he told me and my family that we lied to the hospital about waking up on the table. And that I made the decision to get the surgery, so therefore I knew what the outcomes were, both short-term and long-term. So when you think about a patient who is living in a situation like mine, where you're facing multiple diseases from kidney failure and the complications that come with it, you have to ask yourself as a physician, what can I do to make their life easier? What can I do to help them when they're not here? You have to think about, when I go home and you're putting me on 20 medications, can that patient afford that? And it's always the question of, should I have to choose between going to the doctor and having enough gas to get to the next place? Or should I have to choose between going to the doctor and being able to pay for the medications after? There's been many a times where I've been afraid to go to the hospital. Like recently, I didn't know I had COVID, and I didn't know my potassium level was at 9. But I felt like I was going to have a heart attack, so I called 911. And they were better to me on the EMS than they were at the hospital. The hospital treated me terribly because they said, oh, you're 32. This is not your medical history. There's no way you've been through all of this, when they looked at my history. And I kept telling them the symptoms I was having, but the woman kept making me feel like my pain was not real. So it's just been a ever-evolving door where we see physicians forget that just because you have the knowledge and the training don't mean that you always know what your patient's going through. So just understand that empathy and compassion goes a long way, and it does allow a patient to live with those experiences, both good and bad. So just remember those interactions and how important they are.
Thank you, LQ.
Something I wanted to add, it goes back to solidarity. So even if we had true solidarity, we probably would not have terms like minority. We wouldn't have to use that because no one would be a minority. I come to the table and I am a priority, right? Because I am the patient. And so you listen to me. So even when I hear a story and all the other stories, one was empowered, one was not. And that's the concern I have when we do not empower our patients, right? Because my medical knowledge is not the same as the white coat that comes and cares for me, should not make me feel less than. So how do we bridge that, right? Even when you talk about preventive measures, right? The education, what you can do to not get to this point in life. That preventive measures, the education, that should be offered naturally. Even you should never have to make the decision, can I put gas in my car or if I can get my medicine? I mean, these are the things that we in healthcare, as healthcare providers, really can take a stand. And I'm going to a whole new different ballpark. I talked about lobbying. I mean, physicians, you have so much power, but enough power to also to change the game, to make this beneficial for the very people that you're caring for and have compassion for. Yeah.
This brings me to my next question. This was targeted for you, LJ. Is that, we look at the numbers in medicine, and even the specialty I'm going into, only 1.9% of orthopedic surgeons are actually African American. And so, there are less than 500 of us that exist, which means patients are likely going to be cared for someone who is not from their demographic. And so you as a provider, and then you also as a Black woman, you've been on both sides of the coin. I wanted to ask, how can those that are Caucasian or come from a different demographic than their patients, how can they better bridge that gap? What would make the patient feel comfortable? And I'm going to extend the same question to you as well, from your perspective and your background.
That's a good question. And so while I may not have the answers to all of that, but I think it goes back to seeing the soul of the person. There's a human being in front of you. If this was your mother, if this was your father, if this was someone you love, your spouse, how would you treat them? How would you care for them? What all do you want them to know? What all do you want to know about them or how they're feeling, and actually validating, affirming how they feel? The other thing is when I think about being an African American and not actually being understood, that while I'm dealing with a physical issue and that I don't have all the answers, I'm coming to you because you are the paid professional who is educated, licensed to help me, right? The other thing, when people have faith, right? So use the resources, help that individual to understand what their resources are, and to use those resources to help them in this part of the journey, right? There's so much loaded in that question. It really is. And so I think I'm even guarded as to how I'm answering it and responding.
Yeah, I have thoughts on some of the things you've just said, like paying attention to the story, and how would you treat your mom? And there was something else you just said. What was it?
Talk about even your faith, how your faith is involved, or
Well, there was. Well, that I think when The story you shared, LQ, about a physician not even touching you, not even coming close. I think, you know, I can hide in my privilege, right? And I can empathize sometimes with providers who behave that way. Not because I think it's okay, but because my assumption, and this is part of, I want to encourage us all to like check out our assumptions. Oh, and I remember my assumption is that standing at the door and saying, I know all I need to, that's really about the physician's ability to be in touch with how they are feeling, or inability to be in touch. And the only way you can actually get this close to another human being is to have some feelings. You have to be in touch with your own feelings. And we can talk about that till we're blue in the face. LJ and I could like probably have a weekend retreat on that right there. But you may have aced biochem, right? You may really understand how all of the different medications you prescribe are going to interact with each other. How do you understand how that person's daily life? So if this was your mother, and also don't go in and assume that your mother, who whatever her habits are the same as this person who is the same age as your mom. But use that to be curious about, okay, what are your habits? Are you watching Jeopardy every night? Or do you like to go to the gym all the time? And how is that going to impact? You probably have a lot of training in how to assess those sorts of things, but get even closer to the human being. If you can't touch that human being, you need to think about why. And you're also well trained if you're coming to the medical professional as this is the educated person, this is the person who has passed their boards. That also means that this is the person who has learned how to find more journals on whatever the presenting symptoms are. So just because you already know XYZ about something and you've had lots of experience in something doesn't mean that this new symptom or this new person's whatever that isn't meeting all of the treatments you've tried hasn't already been studied somewhere else. What might you not be aware of? Are you conscious of whatever the person's background is and what what demographically they're more likely to experience medically? And are you looking at how what they're talking about might be related? I don't know if that made any sense. Well, it made me think of one example. So there was a learner we had during the week of their palliative rotation. And the person came to me and said, I'm so upset, I need to talk. So I said, what's the issue? They said, well, African-American patient, lots of pain. I think I shared this with you. Lots of pain. I go back to my attending and I share everything. And I said, I think we need to change the pain regimen. And the response was, they're used to it. They have a high tolerance of pain. So even at that moment, I had to pause I had to check my own feelings because I wanted to make sure that I was understanding. And I said, are you sure that's what they meant? And they said, yes, I just want to talk about this. And so we had a nice conversation. It also gave me an opportunity to say, I'm upset with you, right? But it also confirmed some of the things that I thought was going on, but had not been privy to hear it with that particular patient, right? And also this patient was an elderly patient. So who is the advocate for the patient? And a physician or anyone in the medical field, even myself, should be the advocate for the patient, the person who is in need, no matter what my implicit or explicit biases are. So maybe that's one thing. As individuals, we need to admit to our biases and begin there to deal with it so it does not become a hindrance in caring for the very people who are in need. Sorry. One more thing. We need to admit our biases.
Yeah.
But if we're not conscious of our biases, we need to read research that demonstrates that there are biases that we're not conscious of. So this thing about Black patients and pain, there is a ton of research on this. If you have not read it, you should look it up. There's a lot of research on how physicians historically and present day still are not treating Black pain the same. Do not read Black faces in pain the same way they read white faces.
Yes, and it sounds like empathy and curiosity just end up being the underlying theme here. I mean, I can't relate to you and what you've done. I can't relate to you and your experiences, but I can ask questions empathetically and being actively curious to finding out more.
Yes.
So the next question I really have is geared towards you, LQ. Now, I had an opportunity to do an interview with you and ask you a bit about your experiences and what it was like coming to the doctor, what it was like, mentally, how you were able to handle that. And I think your story was very compelling. I just wanted to ask, can you talk to us about how that felt coming in when you had to hear that your kidney transplant failed, that you were taken off the transplant list? Can you talk to us about how you managed that and what that was like from your perspective and what you would have wanted your physician to have done differently?
Yes. So, when I was 17, I went into complete renal failure, so I ended up losing my left kidney. And prior to that, I had lost my left kidney. I had lost my left kidney to cancer and my right kidney to just genetics as well as just disease in general, as complications of the kidney disease and the cancer. And so going forth, the way that I was treated when I was 17, going to the children's hospital, the experiences were amazing. When you walked in the door, they treated you like you were their children. They gave you the world when you walked in there. But when I transitioned into adulthood and I started going to doctor's appointments, life got really different for me. People started to see more of my race than who I am as a person. They started to see my age than me as a person. They started to see my sexual orientation before seeing me as a person. So it got to a point to where I felt like I needed to guard my heart and guard my family when we would go into these appointments. And I always went in defense mode, feeling like, well, I need to be prepared to already have this information presented. So I got to a point to where I was literally writing down all my medical diagnoses, all my surgeries with the dates, all my medication lists, because I didn't want anybody to ever make me feel like I was incompetent, regardless what type of specialty doctor I was seeing. But I remember the day in 2015, it was July of 2015, I went in to see my nephrologist, and she sat me down and said, Ms. Godering, I know this isn't the news you've been waiting on, but I'm sorry I have to be the one to give you the news. Your transplant is failing, and you will need another transplant. I need you to sit and think about what that means for you, and do you want to go forth with the testing? Now, for you that don't know, you have to do a 6-month workup process that could actually take up to a year or years. And for me, it just felt like my life was flashing before me, because I knew that meant seeing new doctors. I knew that meant new experiences and trying to build new relationships and trying to break down the barriers that's already in medicine and in transplantation alone. It's just unreal to see that I've had to lose multiple family members who have been waiting on kidney transplants and who have been mistreated by the medical system just like me. Just imagine what it's like to go into a doctor's office and somebody to make you feel like your pain isn't real, but I see that your kidney's failing. Oh, I know that you're in heart failure, but I don't really know what to do for you. Oh, I don't want to treat you because of your history. And to have doctors literally have you come in, pay for these appointments, and send you on your way without doing anything. Just imagine the mental capacity that takes on one person to have to turn around and leave a doctor's appointment, go home, hook yourself up to a dialysis machine, run for 4 hours, take yourself off, do your own blood work. This is a ritual for me and my family. This is not something we get to take a break from. And so when it comes to healthcare experiences, we're very mindful of the doctors that we choose, because I'm not going to choose a doctor that's going to make me feel bad about being married to a woman, or make me feel bad because I'm a Black woman. I'm me. My identities are intersectional and I can't separate them. I deserve empathy just like the next person. You might not understand me because I'm Black. You might not understand me because I'm a woman, but it's important for you to sit with me and sit in the knowledge and know that this is a learning, ongoing experience for both of us. Being on dialysis for 7 years has not been easy. You know, I'm dealing with the ups and downs of trying to protect my heart health, trying to protect my other organs, managing my potassium, my phosphorus levels, my electrolytes, my fluids, just being aware of everything I'm eating and drinking every day, as well as keeping up with 6 different doctors I have to go to every 6 months, if not sooner. So just last week, I had heart testing, and I was afraid that this one test could kick me off the transplant list. I have been taken off the transplant list 3 times now. The first 2 was because of insurance, but this last time was a mishap that happened in the medical system with my team. They didn't make sure that prior authorization was filled out to send to insurance. So they made me do all these testing that wasn't even required, like getting a drug test. To me, it's making me feel like I'm doing something wrong in my life, and I can't just tell you I'm not a drug addict, but because I'm Black, you don't believe that. I feel like race is only one aspect of medicine, but it is a big part of the experiences that I've had as a young woman at 32 alone. And just this past several weeks, it has been experiences where I went into the doctor's office and you're being told, like, well, your heart function, even though it's increased, you're still at risk of multi-organ failure because of dialysis, because you're in kidney failure. And then when I think about coping with all of this, you have doctors that tell you, go seek mental help. Well, I did that. And one of my transplant kidney doctors looked at me and told me she was ashamed. She didn't want to work with me. She was disgusted by me because I took the initiative to go get help. And instead of saying, I'm glad that you went and got the help, she discounted the therapist I was seeing because she was Black, because she didn't feel her education matched their team. So therefore, she was like, I want you to see a U of L psychologist, a U of L psychiatrist, before putting you back on a transplant list. Now, how fair is that? I'm a patient that overall takes care of myself every day. I manage, between me and my wife, we manage all my health ups and downs. I'm taking the initiative to stay mentally well as well as physical, but sometimes it's not enough for physicians to see because they're not living in your shoes. Just take a minute and try to live in my shoes one day at a time, just trying to figure out what can I do to make the experience better next time. Thank you.
Okay, your story is jarring. I'm so sorry that you had to experience that, and I'm just so proud of you for how strong you are. And so for me as a medical student, this is very meaningful. I mean, I wish I would have had this conversation and been able to see and hear from you much earlier in my medical education. And so for all of you, as we're finishing out, I just have one last question. Medical students, healthcare providers, so many people are going to be watching this, and I want to ask, what is one thing that you want them to take away from this conversation that you wish that they knew when you interact with them? What do you wish that they would take away from this and apply to their own practice? And I'll start with you, Les.
Thanks. My heart rate went up as you were telling your story. I'm still trying to cool myself down. When you asked the question earlier to both LJ and I forgot to name heteronormativity. I got so involved in my responses to what I was hearing. But heteronormativity is one of the big barriers for care for the LGBTQIA community. And so that's what I would say. I hope you take away, at least from me, the idea that if your life is heteronormative, great. And if you live in a world of heteronormativity in your personal life, more power to you. That's great. But in your professional life, if you're a physician, please learn more about how your heteronormativity impacts your clinical practice. So if you don't know a lot about intersex people, that's another, we could talk about that for an hour and a half. If you don't know what an intersex person is, please look it up. Katie Couric has a great documentary on intersex people, not intersectionality, intersex. And in all of your practices, look for resources that promote inclusive care. So there's a great book by Kimberly Aquaviva. She's a nursing professor at UVA, sorry, and she writes about palliative care and providing inclusive palliative care. The thing that's key about this book is not that LGBTQIA are a separate thing that need a separate thing, a separate kind of care. She's incorporating normalcy of LGBTQIA into how she's teaching palliative care and using examples, making LGBTQIA people normative while teaching basic principles of palliative care. So you could use that text to learn about palliative care just by itself. It resources all of the best texts. And I would imagine you could probably find resources like this in every discipline. Look for resources to think about how you increase inclusivity in your care.
I hope people will understand that they need to see and listen with empathy, right? Have that empathic listening skills. Affirm, respect, honor, and believe the person who's sitting right there before you, who is in need of your support and care. And believe it or not, sometimes we do know what we need. You needed a specific therapist and it was working. We know what we need as individuals and believe that. So I just hope that is some of the things that we take away.
Just to go back to what both you ladies said, I think it's important to be empathetic as well as to recognize the implicit biases and just having that autonomy so that those open relationships can begin, and being honest with your patients when you don't know something. To me, that's more important than you walking in, citing a whole medical book, but also making me feel like my time is valuable to you. Don't come in the room and the first thing you do is keep looking at your watch. To me, I've had a lot of physicians do that, and I understand your time is important, but also understand mine is too, and you're getting paid and you can be fired. So just know that that is out there. But also, I think it's important to know that when you walk in the room, I know that you're wearing the white jacket or you're the nurse in the scrubs, but just remember to put yourself in the place of where that patient's at. If your patient's in the hospital laying in the bed, don't come in the room and talk about what you're getting ready to do when you leave, because they don't get to just walk away from whatever they're going through. So make them feel comfortable, make them feel respected, and give them the time that they need to be able to say, these are my symptoms, please help me. When a patient is in your face crying out for help, don't just think that you know it all and walk away from the situation because you feel better, that they feel better. Just making sure that you do seek out resources, such as working with nonprofits or sending your patients to nonprofits that are within your field of study. That's another important resource that I had to actually share with my own medical team, and has opened an avenue of respect on both ends and has allowed me and as well as the physicians to get involved. So, but always see medicine as something that's an ever evolving learning process with your patients. So always be willing to listen and to learn even when their symptoms are not in your medical book. Know that they're real, know that pain is real, and know that pain has no face, no name, no race, no age, no weight limit. I think that a lot of the times we always want to throw those things at the front line and forget what we're actually treating and why we both showed up today to this discussion. So thank you.
Good.
All right. So basically, this is my complete setup for dialysis, home hemodialysis. So what that is you hook up to this machine here, and it has all its lines that go right here inside the machine, and then the fluid to be able to clean your body. So what happens is I'll hook up to this machine using these two needles here, which I'm stuck every time with these two needles, and then I'll use heparin, of course, to be able to keep my blood clear so that throughout the time that I'm running, I'll be able to get full clearance on the dialysis machine. So how this works is this will go into the machine. The needles will go into my right arm. Let me show you. This is my fistula, and I'll be stuck here and here each time so that I can run properly on dialysis. And so with that comes its own pain. So now they have pain ease for patients to be able to help with the process. And basically this is all my supplies. So what I usually do is I turn on this machine and I'll connect my fluid here, and these are my fluids for the machine. It'll cycle through like this, like a O, and as the blood is being pulled from my arm, it'll go into this machine, it'll go through all of this, and there's a little dialyzer that, so this little thing right here is called a dialyzer, and it's basically an artificial kidney that keeps a patient on dialysis alive. So this little thing right here removes all the toxins from basically head to toe out of my body, so that when I get off this machine, all the fluid, all the toxins, everything that I've ate and drink that could be sitting up in your body making you sick is pulled onto this machine and out of my body, and all the blood pulled back into my body is now officially clean. I run for about 4 hours, 4 days a week, and when I get off, either my blood pressure is really high, really low, or I'm feeling okay. So there's an imbalance in electrolytes, so you just never know if you're going to be ready to get up and run, if you're ready to lay down. So this is my experience. Even through undergrad, I was hooking up to a machine similar to this, anywhere from 8 hours to 10 hours a night, and then I switched over to the home hemo machine, where I hook up now for 4 hours, 4 days a week at home.